Hey guys, so in this video I'm going to revise ortho and I will try to revise in just one shot. So it will be a long video if I will able to do that. So let's hope. Now ortho is not something that I like to read and all, but I don't have any option. So I'm trying to best to understand this one. So let's start with one of my weaknesses, that is actually lower limb. Actually I was going to start with some basic like what is the structure of bone, their metabolic diseases, then fracture and basics about the fracture, then going with all the upper limb, lower limb and spine. But I feel that by that approach I reach to the lower limb and spine, I will be exhausted, and I have always skipped that topic. So I am not going in the basics, but if I will able to finish my this two hated system, that is lower limb and spine, I will then cover it by the basic approach. But let's first cover this two. And if you want to watch from the basic, you can directly go to that part, and in the end I will mention what is the timing of different system that I am covering. So let's start with the lower limb. So first is the lower limb. Now let's learn about the first joint, that is our hip joint in the lower limb, the anatomy part. So anatomy of hip joint. It would be better if I cover simultaneously the anatomy part of the lower limb, but it will be then too much for now, as I am just revising the ortho. So I am just covering what is there in this one. So first we have to see gluteus medius and minimus and their mechanism, while how they are helping when we are walking. So first let's talk about the gluteus medius. So gluteus medius origin is from the dorsal ilium inferior to the iliac crest. So dorsal ilium inferior to iliac crest, and insertion is lateral and superior surfaces of greater trochanter. Lateral and superior surfaces of greater trochanter. Now what is its action? So major abductor of the thigh. And it is innervated by superior gluteal nerve, that is L4, L5 and S1. Now what will happen if this superior gluteal nerve that is supplying to the gluteus medius and minimus is injured. So let's see. When we are walking, what actually happens that when we are lifting our one leg and all the body's weight is gonna transfer to this other leg. So this leg is lifted, means off the ground, and this one is supporting the whole body's weight. So if this leg is lifted from the body and other leg is supporting the weight of the body, what will happen? This other leg, the muscle of the muscle that is gluteus medius and minimus will contract, and that will prevent the down falling of this other leg. So lurch won't happen to the affected site. So you can remember by this way, there is this fulcrum and all of the load is here. So here is the power. I actually am not able to understand what is this mean, but now what will happen if these two are affected? Then means weak gluteus medius, then this side will drop. Okay, that is called as lurching gait. So it will be painless and trunk deviates towards the disease side. Why this will happen? So pelvic drop will happen, and to prevent this, what will the person do? It will deviate the trunk this side, I mean the affected side, so that this leg won't fall down, I mean won't drop, pelvis won't drop. So lurching is towards the affected side. What are the example of this condition? So there can be developmental dysplasia of hip, superior gluteal nerve palsy, or poliomyelitis. So developmental dysplasia of hip, poliomyelitis, and superior gluteal nerve palsy. Now it is unilateral, then lurch or abductor or treadle Berg gait. If it is bilateral, then it is called as duck waddling gait. Now the differential diagnosis of this gait will be limp, and this is mostly due to septic arthritis. So what will happen, due to pain in the septic arthritis, patient will try to deviate the trunk towards the normal side to avoid the pain. So it is a painful condition, and the trunk will deviate to the normal side and it will happen in the mostly septic arthritis. This is known as, it is a unilateral condition, limp gait, limping gait, or antalgic gait. Antalgic means it is to avoid the pain. Okay, now we have to see what is the radiological anatomy of hip. So there is various lines that we have to learn to see if the hip anatomy is normal or not. So let's understand by the diagram. I think it would be better if I just search this in the Google about the Shenton's line and Perkins line. Yeah, this image is better, I think. It is showing all of the things. So it is showing all the things that I want to show you. So first learn about the Shenton's line. As you can see, it is an arc. Actually, it is an arc that is connecting the inferior margin of the superior pubic ramus. So actually it is a superior pubic ramus and the inferior margin of superior pubic ramus to medial aspect of the neck of femur. And what are the pathologies in which it is a broken? So let's see. Developmental dysplasia of hip. Again, it is the example that developmental dysplasia of hip, it will be broken. Example, developmental dysplasia of hip. Now about the Perkins line. So Perkins line is a vertical line and Hilgen-Reiner line is a horizontal. So you can remember that HH, it is a horizontal one. And how are you drawing? So connecting the centers of the two acetabuli. So we can see these are the two acetabuli, and the center of the two acetabuli, the horizontal line connecting it is a Hilzeng-Renner line. Okay, so center of two acetabuli, and the vertical one is a Perkins line. And how are you drawing this line? So from the superior acetabular margin, here you can see, from the superior acetabular margin as perpendicular to the horizontal line. Now what are the Perkins quadrants? As you can see, there are 4 quadrants that these two lines are making. When the line 2 and 3 intersect each other, they create quadrants, mean normal location of the head of femur and is in the, as you can see, the normal location of the head of the femur is in the inner and lower quadrant, means here. But in developmental dysplasia of hip, it will be in the upper and outer quadrant, as you can see. So here you can write that head of femur is in upper and outer quadrant, and normally it is in inner and inferior quadrant, lower quadrant. Now one line that I haven't shown is the Kleins line, so let's put the image of that also. So the Kleins line, as you can see in the image, the Kleins line is a line along the superior surface of the neck of femur, seen intersecting head of femur, but in slipped capital femoral epiphysis the line won't intersect. So this is so normally it is the intersecting, but in slipped it won't intersect, as you can see from this diagram. So this one is a and this sign is very important. It is Trethovan sign. So this we have to remember this two terminology, that is Kleins line and the Trethovan sign. This two. This Perkins and Hilton Renner is also important one, but Shenton I know very well. Now let's see the blood supply of the hip. So blood supply of the hip joint. So femoral artery will give two branches mainly, that is medial circumflex femoral artery and lateral circumflex femoral artery, but this will contribute more to the blood supply of the hip joint. And also the another artery is profunda femoris. I think this two is the branches of this one only, femoral artery. And there are also some other femoral artery branch. Okay, now there is also obturator artery, and this gave rise to the foveolar artery. And also epiphyseal artery, ascending cervical retinacular artery will also supply, and it will be a retrograde blood flow, means it will be from distal to the proximal, and retrograde blood flow will be seen in the hip joint, scaphoid, in the talus and patella. So profunda femoris will give rise to the lateral circumflex femoral and medial circumflex femoral, but medial will contribute more to the blood supply of the hip joint. And there are obturator artery which will give rise to the foveolar artery, which will pierce the ligament of the head of the femur. And there are also arteries like retinacular artery, also known as ascending cervical, and epiphyseal artery. So this was the blood supply. I am writing the other name, that is epiphyseal artery and ascending cervical or retinacular artery. Okay, so before going to the pediatric hip disorder, I think I want to see wait. So I have learned about the arteries of the lower limb. So arteries of the thigh, so main artery is the femoral artery, and femoral artery is a branch, not a branch but direct continuation of the external iliac artery when it becomes femoral artery. So when it crosses under the inguinal ligament and enters the femoral triangle. In femoral triangle, the profunda femoris artery arises from the posterolateral aspect of the femoral artery. It travels posteriorly and distally, gives off three main branches. So perforating branches, lateral femoral circumflex artery and medial. These two we have seen. So this profunda femoral artery arises from the posterolateral aspect of the femoral artery, and it will travel to posteriorly and distally and gives 3 branches. So perforating branches consist of 3 or 4 arteries that perforate the adductor magnus, contributing to the supply of the muscles in the medial and posterior thigh. Now lateral, femoral and medial will wrap around the anterior and lateral side of the femur, supplying some of the muscles on the lateral aspect of the thigh, wraps around the posterior side of the femur, supplying its neck and head. In fracture of femoral neck, this artery can be easily damaged and avascular necrosis of the femur can occur. Now obturator artery arises from the internal iliac artery in the pelvic region. It descends via the obturator canal to enter the medial thigh, bifurcating into 2 branches, so anterior branch and posterior branch, and this supplies the pectineus, obturator externus and adductor muscles and gracilis, and posterior branch will supply the deep gluteal muscles, and the gluteal region is largely supplied by the superior and inferior gluteal artery. These arteries also arise from the internal iliac artery, entering the gluteal region via the greater sciatic foramen. Okay, so this was about it. I mean, the main artery of course of the lower limb is the femoral artery, which is the continuation of the external iliac artery, and it will continue as a popliteal artery, and popliteal artery will divide into the 3 main branches, that is anterior and posterior tibial artery and common peroneal or fibular artery. So arteries name is just like that of the bones, but some arteries are not really related to the bone, that are extra ones. So here we have remember that from the internal iliac also some contribution is going there, which is superior and inferior gluteal arteries plus obturator arteries, that is same like that of a nerve. And obturator, we know that obturator is mainly supplying the medial compartment when it is related to the nerve. So here see the adductor muscles are also supplied by gracilis and obturator externus and pectineus, and posterior branch is supplying the deep gluteal muscles. So just like that only. And we have also seen this 2 artery also. So obturator artery here will supply the foveolar artery and epiphyseal artery, and ascending cervical or retinacular artery will also be there, but it is not very important. You just have to remember this medial circumflex and lateral circumflex. Medial circumflex will contribute more, and it will mainly supply posteriorly and medially, and here it will mainly anteriorly and laterally. So this is the main, I think, supplying the head and neck. And when neck fracture will happen, avascular necrosis of the head will happen due to this artery. I think this is enough as of now about the blood supply, normal anatomy, all the lines, and this gait we have seen. Now we have to learn about the pediatric hip disorder, in which we will see the osteochondritis of head of femur, also known as leg cow Parthes disease. So Parthes disease is the next one. And then we will see the developmental dysplasia of hip, and mainly this thing we have to remember. Okay. Also, slipped capital femoral epiphysis is also one disorder that we have to learn. Then we will see the basics of the knee ligament, their anatomy and what will happen if there is an injury.